All over the world, we have 43 million people suffering from AFib. This number will even increase during the next years, looking at the digital health. Our real-world data from the TriNetX database from the US shows that AF alone is associated with a 16.6% mortality rate over 10 years. Looking at heart failure alone, it's 21%. But those patients who are suffering from both, it's even increasing up to 32%. We already know that there's an interaction between the heart failure and the AF. This leads to less quality of life, higher stroke and mortality rates, and even double hospitalization rates. Looking at the real-world data again, there were over 5 million people suffering from heart failure and AF. But they are not all the same. We have to look at them more precise. There we have 1/3 in the HFrEF group, 15% in the end-stage heart failure group, and even 30% in the HFpEF group. But how should we treat them? So we have already the Castle-HFpEF trial, which showed that catheter ablation reduces mortality and hospitalization rates in the HFrEF patients. There, the all-cause mortality was reduced nearly by 50%. On the other side, there's even the Castle-HDX trial, which shown the end-stage heart failure guys. Those we're looking at end-stage heart failure, looking at LVAD implantations, heart transplantation, or all-cause mortality, and there was a significant benefit on those patients who undergo catheter ablation. Therefore, the last guidelines even changed to a class 1A recommendation, so first-line therapy for HFrEF patients to improve the quality of life, their symptoms, and their cardiovascular outcome. But what should we do with the HFpEF patients? We don't know yet. The heart failure community is still not convinced that they will benefit from catheter ablation, like we can see in one editorial from 2022. Even looking at the heart failure guidelines, they're just mentioning to manage AF in HFpEF patients, but we don't have any directed guidelines with more details. So we have two questions to answer. First, should we screen HFpEF patients for AF, and if so, how? And second, how should we treat those patients with HFpEF and AF? The prevalence of AF in the HFpEF patients is not well established. There's a wide range coming from 16 up to 65% in several studies, but it's not consistent. But how should we treat them? Looking at the medical therapy, we have the classic medication we use for the heart failure population, especially the diuretics and SGLT2 inhibitors, with a better recommendation. But if we look more on the SGLT2 inhibitors, like in the Emperor Preserved study, we have seen that more than 50% of those patients were suffering from AF as well. There, the SGLT2 inhibitors reduced the composite endpoint of cardiovascular hospitalization and cardiovascular death. But how should we optimize those patients who are still having the symptoms? The catheter ablation in the HFpEF group has already shown that it's associated with less hospitalization, less all-cause mortality, and heart failure hospitalization rates. Or looking at the right, we have the sub-analysis from the Cabana trial, which shows less death, stroke, and cardiovascular hospitalization rates in the HFpEF patients. But until now, we don't have a randomized trial who is looking and evaluating the role of catheter ablation in the HFpEF patients. The latest data from 2019, we have seen that only 1% of those HFpEF patients were undergoing catheter ablation. We improved already this number up to 7% looking at the last 15 years in the Tulane University. But it's still just a small number of patients who is getting ablated. So we want to know how we can help our heart failure colleagues to improve the outcome of the HFpEF patients and see if the ablation is really beneficial in those patients or not. So it's time for the Castle-HFpEF trial. The Castle-HFpEF trial itself consists of 2 phases. First, the screening, and then the treatment phase. During the screening, we want to include 4,000 patients with only a short history of AF, less than 4 months, or even no history of AF, and the classic heart failure population of HFpEF. After this, the paroxysmal AFib patients and those without any AF history will be monitored for 30 days, looking at a burden who should be bigger than 1% or at least 1 AF episode for at least 24 hours. You might ask why we are choosing the 1%. But we are saying the burden is the new plaque, because even a burden which is bigger than 0.1% was associated with a higher healthcare use, looking at hospitalizations, antiarrhythmic drugs, ablations, and cardiovascular hospitalizations itself. Therefore, we want to include those patients, and if they met this inclusion criteria, we will optimize the medical therapy according to the guideline-directed medical therapy, including SGLT2 inhibitors, diuretics, ARNIs, and MRAs, for at least 4 weeks. After those 4 weeks, the patients will be randomized either to the ablation or the medical therapy group. In the ablation group, PVI only will be at first the standard of care, but the treating physician can decide to do more if it's necessary. Here, we recommend to use the Varipulse or Faropulse catheter, but everyone can choose. On the other side, we have the medical therapy. There we have either the rhythm control or the rate control. Rhythm control should be always aimed in every patient who's undergoing the medical therapy, but if it's not possible to maintain the sinus rhythm with using antiarrhythmic drugs like amiodarone, dronedarone, sotalol, then they may even just go to the rate control, aiming a normal frequent heart rate between 70 to 90, using beta blocker or digoxin. After 3 years, we want to look at the endpoints. For the primary and secondary endpoint, we want to do a win ratio analysis. The win ratio analysis of the primary composite endpoint will be using all-cause mortality, strokes, hospitalizations for worsening heart failure, and a decrease in NT-proBNP. The secondary endpoint will include all individual primary endpoint components, and it will look at heart failure related events, quality of life, burden, AF-free interval, NYHA classification, 6-minute walk test, to include really most of the heart failure symptoms and to get a good knowledge how to treat those patients. To conclude, I want to say that with Castle-HFpEF and the Castle-HTX trial, we have already changed the guidelines to class 1A recommendation in the HFrEF group. And now, with the Castle-HFpEF trial, we will hopefully answer 2 questions. First, what is the impact of newly diagnosed AF in HFpEF patients? And what is the best treatment strategy for those patients? Thank you very much.